Well, hello everyone. I'm glad you could join us tonight. Tonight we've got a special guest, Dr. Margaret Naeser, and we will be talking about how PBM can improve things with the brain. And I will get into that in a minute here, and we'll invite her on in a minute. But first, I just want to do a little bit, just mention that we will be able to have Dr. Margaret Naeser on as again next Tuesday. And so please tell all your friends. We'll be talking about PTSD, strokes, many other things. So I would like you to reach out to all your friends to join us. So for all those that are joining us tonight, you will be entered into the draw if you stay to the end. You will be, once a month, we draw for the Super Palm. That's the Super Palm 1050 device, and that's valued at $1,900. So, you know, it's every time you show up for our webinars, you get another ballot put in. So at this point, I want to waste no time and introduce you to Dr. Naeser. And Dr. Naeser, if you can come on, well, I'll start. Now, I'm going to read a bio of Dr. Naeser, and this is really the Cole's Notes version, because if we did the full version, I think we would be tying up the first 10 minutes of our program. So here we go. So Dr. Margaret Naeser, PhD, is located in Boston VA Medical Center and is a research professor of neurology, Boston University, and Chobian, I'm not sure about that, Navita School of Medicine. Since 2010, she has studied the effect of near-infrared light-emitting diodes placed over the scalp, brain, to treat traumatic brain injury, PTSD, dementia, stroke aphasia, and Gulf War illness. She has a strong interest in neuroplasticity and utilizing transcranial photobiomodulation, tPBM, to promote neuromodulation for brain recovery. This includes resting state function connectivity, MRI, and magnetic resource spectroscopy, MRS, pre and post a series of tPBM treatments. She has had a VA / NIH funded research for over 40 years on the neuroanatomy of stroke location in the brain, on CT MRI scans in persons with aphasia. She has published research using transcranial magnetic brain stimulation to improve language in chronic stroke aphasia. She has over 100 publications, and she is on the editorial board of photobiomodulation, photomedicine, and laser surgery, and fellow American Society for Lasers in Medicine and Surgery, ASLMS. She has received her BA from Smith College and PhD from the University of Wisconsin-Madison. She has been a licensed acupuncturist in Massachusetts since 1986. She has conducted research with acupuncture and laser acupuncture to treat paralysis in stroke and pain in carpal tunnel syndrome. So she has a book, and she'll refer to that. It's called Laser Acupuncture, an introduction textbook for treatment of pain, paralysis, spasticity, I'll get to some of these words out, and other disorders. Clinical research users of laser acupuncture from around the world. Boston Chinese Medicine, and 1994 to 2024 with the www.lhasaoms.com. So with just this short reading, I want to welcome Margaret, Dr. Naeser, for coming on tonight. Thank you so much. You are going to blow some people's minds with what, well, we're actually trying to treat minds. So
I want to fix them.
You're trying to fix them, not blow them up. So if you'd like to take over the slides here, and we're ready to go. There you go.
Okay, thank you very much. I'm looking forward to this. And you saw from the title of the talk, it's Introduction to Basic Mechanisms of Photobiomodulation, or PBM. And then we'll quickly go through research with traumatic brain injury, chronic traumatic brain injury, and then some ex-football players who possibly are developing chronic traumatic encephalopathy. I don't have any financial conflicts of interest to declare. Our research has been funded by V-Light from Toronto and Thor Photomedicine from London. And the VA and NIH grants have also helped us to do our work with transcranial photobiomodulation. But nobody in my lab has any financial conflicts of interest. Now let's see, I'm not getting very far here with my advancing. There we go. So now I didn't get back to all, yes, the second slide was listing all of my co-investigators, and they've been wonderful for actually over 15 years right here in Boston doing all of this photobiomodulation work. So yeah, we have three parts. We're going to get going with talking about the basics, and then TBI, and then the football players. So part one, it's what is the definition of photobiomodulation anyway? So photobiomodulation, or abbreviated PBM, is a non-thermal, there's no heat involved, application of photons, which are just light particles. You have them all over your house if you have anything lights turned on, to improve cell function. We're going to try to fix cells with this. And normally, we're working with photons, or these light particles, that are from 600 to about 1200 nanometers. And the red wavelengths, you can see our visible spectrum as humans. This is what we can see. It's quite limited, actually. And we can see from about 400 nanometers, which is pale violet, all the way through the rainbow, green, yellow, orange, and then red, which is 700 nanometers. And then after that, our eyes don't see it. So we go into what we call near infrared, which is about 800 nanometers. But that wavelength, the higher the numbers here, the deeper the penetration of the photons or light particles. So the red wavelength, 600 to 700 nanometers in here, are visible red. You can see them, they're kind of orange red, and they're going to have a shallow penetration, only about 1 millimeter. The red is used often for skin and wounds. But then the longer wavelengths will have deeper penetration. And the near infrared wavelengths of 810, 850, 870 are commonly used. And they'll go 1 or 2 centimeters based on research from 1981 over to 4 or 5 centimeters now with more recent research. And on the graph to the right here, you can see 400 nanometers, which was just pale violet. It's not going to go very deep at all, 1 millimeter maybe. And then when you get up here to 700 nanometers, a nanometer is a billionth of a meter. And so you get to 700, oh great, now it's red. Okay, it'll go 1 millimeter anyway. And then you get to 800 and 1000 and 1200, and they're just going to go deeper and deeper into the tissue. And that's a very important concept. You can't see these numbers, these 800 ones, but they are going to go deeper. Now, down here in the lower right-hand corner.
Excuse me,
yes?
Dr. Naeser, one thing I wanted to point out here is this was dependent on a certain laser light that they had done studies with. And
this was originally done with lasers, definitely.
Yeah, and what we've been able to show is that we can get much, much deeper penetration with larger area and more power. As long as we're not heating up the scalp, we can get much deeper than these numbers. But this gives you an idea what happens. This is a good chart to show what happens when...
And this is with your devices from, LED devices, the handheld
Yes,
ones.
that's correct. Because of the large area, you're able to increase the penetration. Go ahead.
Yeah.
I'm
this is
sorry.
Actually 3-inch diameter, but no, I think that's very important. And it's wonderful because the lasers really have a small diameter aperture, but the aperture is like 3 inches on these handheld devices that are LEDs. And there's a reason why we don't go much below the 600 nanometers right here in the lower right-hand graph. It's because if you use smaller wavelengths down in here, the hemoglobin in the blood is going to start to absorb those photons. And that can be very good if you want to irradiate blood, but we don't always need that. We don't want to get in the way of our delivery of our photons. Down here at 514, for example, that's sort of a blue wavelength, and they've discovered that 470, 500 is very antiviral and very antibacterial. So in any event, we normally are not working with wavelengths that are shorter than the 600, 700 for the red. And then if we go too high at the other end, greater than 1200 here, the photons will be blocked by water. And that includes water in the skin, etc. So we're kind of basically going to be working with 600 to the 800s or maybe 1000 or so, just so you get that idea. I'm not going to get into the terminology of joules. Joules is a unit of work energy. You probably studied that a long time ago, physics in high school, etc. But we don't have time to get into that today. But it is the basic language of how you talk about how much energy did you deliver with your device, with its LEDs or laser. Quickly with this slide, when the effect of light was discovered back in 1967, red light especially was beneficial to cells that were damaged. They were using gas tube helium neon lasers here in the center. It was filled with helium and neon mirrors on every side, a tiny slit at the end, and you apply electricity. The photons get very excited, and then they come out this little hole down in here. And if it's a laser, those photons are going to come out exactly the same wavelength, and they're going to come out coherent. And that's why laser beams will travel far, and you have Star Wars and all of that sort of thing. But now today, we actually don't work with gas tube clunky helium neon lasers, devices you had to carry around. So I wanted to make sure you understand that we're not working with high power lasers, never have been as far as this kind of therapy is concerned. They're called class 4 lasers. They can be 100 watts, and they're used in surgery for tissue ablation, but they are monochromatic and coherent. And then you have low power lasers that we work with when we were working mainly with lasers, and they're less than a watt, 500 milliwatts, or you can use a laser lecture pointer. You can go buy one, at Staples or whatever, a 5 milliwatt laser lecture pointer. And you can actually treat acupuncture points with that, especially in babies and children. So they are also going to be coherent and monochromatic, but they're considered to be cold lasers. They don't heat up. And they're only a problem if you actually shine it into the eye, but not even 5 milliwatt laser lecture pointers. That's not going to damage your retina. Then we move on in the more modern era here, the last maybe 10 years, working with light-emitting diodes. There's light-emitting diodes on your TV set. They're all over town in traffic lights and so on. But they are non-coherent, but they're monochromatic. So, they're not coming out in this perfect parallel beam here. They're kind of on top of each other, going like this. But so therefore, they're considered non-coherent, and you don't really use them for pointing when you're lecturing for the most part. They're not going to be focused that well, but they are monochromatic for the most part. Monochromatic means they're just a similar color or wavelength. That's pretty simple. No goggles are required, and they're not dangerous to the eye. Now, the modern term since 2015 is photobiomodulation, or PBM, if you search for it on NIH PubMed. And before 2015, it was called low-level laser therapy, LLLT. So a lot of the studies from before are under that mesh term. So we have to move on quickly here. This is rationale for why we would want to use these low-level laser therapies, or LEDs. So we're going to work with cells. So here's a basic cell. Here is a square shape. I like that. None of them are square. But anyway, the nucleus is in the middle. This white border here is the cell wall. And then these little brown organelles are inside. There's thousands and thousands of them. And then you magnify this one mitochondrion, and inside you have mitochondria mitochondrial folds, and they're folding back and forth. And that is going to represent the electron transport chain. And there's these complexes in that chain. And this cytochrome C oxidase down here has got to be working and in good shape, good order, to make ATP, which is the energy for cells to exist. You need them for respiration, oxygenation. So this is the electron transport chain, and it's going to be there to make ATP. Graph over here, and what you can see is with this black dotted sort of beaded line here, that's telling you that cytochrome C oxidase, this sort of last complex in this electron transport chain, is a big time photoacceptor for red. Remember the sunrise and the sunset, it's going to be orange-red. Mitochondria and cytochrome C oxidase love red. And then there's also a peak here for near infrared, and that's in the 800s. So this is put together, this slide by Mike Hamlin from Mass General Hospital. And the issue is in a stressed hypoxic cell, meaning low on oxygen, the up here at the electron transport chain, cytochrome C oxidase is all clogged up, very stressed out, and is clogged up with nitric oxide. That's just the way the cell reacts to stress. Okay, there's low respiration and low ATP energy production. The cell is in trouble. However, if you apply red, see this big arrow here, red or near infrared light, that cytochrome C oxidase up here in this electron transport chain will take it in. And immediately, the nitric oxide that's been clogging it up all this time immediately goes outside the cell wall. Remember the square cell over here in the wall? It goes outside the cell wall. Now, that's a good thing because nitric oxide will promote dilation of blood vessels and lymphatic drainage vessels. So that's a good thing that the nitric oxide can go where it's needed and where you put your LED photons. It's a really good thing. You can direct where you want to help those cells. And then wonderful things happen. The cytochrome C oxidase in this electron transport chain here starts to work again. And you get good respiration and increased ATP for energy metabolism and respiration. And it's very interesting because normal cells don't really respond very much to the photons you're feeding them. But low on oxygen cells, the hypoxic cells, oh, they'll really take it in. And the effects continue for a long time after the light is turned off. And this is going to release nitric oxide is going to increase blood flow where you put your photons. And then the nitric oxide will also reduce swelling in the area by dilating the lymphatic vessels. So there's a lot of good things that happen. Now, this is a cell from the brain. This is a diagram. This is a neuron, a cell body, and the gray matter outside of your brain on the surface, or on the white matter on the inside. And of course, the nucleus is here. But look at all these mitochondria running around, circling around the cell body, the nucleus, and they actually travel down away from the cell body, down the axons. And then they are eager. Let me see if I can get back here. They are going to help to form a new synapse. But when there's traumatic brain injury, there's breakage in this white matter, or this extension of the gray matter cell body. And these mitochondria can't really move along very well, but they actually travel and try to help fix each other. It's a really wonderful thing. So it becomes you see mitochondria travel along the axons. And this becomes very important when we're going to try to fix traumatic brain injury, because there's a lot of breakage and twisting of these axons and brain damage there. So this is just an example of vasodilation after a series of LED treatments. This gentleman, this is a study from Japan. The white out here is the skull bone, and this is the brain, and then this is the ventricles, and there's actually brain damage here on the right side. These images are flipped, and they're going to apply LEDs to both sides of the forehead for 30 minutes. They're going to treat, I think it's every day for, oh my goodness, 3 months of LED therapy to both sides of the forehead. And by the time it's done, you can see in this last diagram on the right, you have increased cerebral blood flow. as seen on a brain SPECT scan. So that's very useful to see. This was a very severe TBI case, and the only thing that really happened was he kept trying to pull the tracheostomy tube out. So there really was no really beneficial exchange here, but we got to see that we really can increase blood flow to the brain, and that's really important. And this slide just shows you that if you put cells on a petri dish, you have a group you don't treat at all, you don't do anything to them, but you do another group of cells in a different petri dish, and you make them low on oxygen. You expose them to nitrogen gas, and then you turn on the light. And what happens is those that were hypoxic or low on oxygen, because you made them that way, are going to increase their ATP production by 6-fold. But if they were just normal cells sort of floating around, not doing much, and you apply the light, they're only going to increase their ATP by 2-fold. So that's why we say that the hypoxic cells, the really brain damaged ones, are what's going to benefit. And then I don't have time to get into all of this, but these are cellular effects. You're going to increase collagen. That's why you see the red light advertised all the time on TV for wrinkles and things like that on the face. You're going to increase energy, ATP, especially in low oxygen cells. You're going to promote blood vasodilation and lymphatic vasodilation. You dilate the lymphatics, you get rid of waste products. That's a really, really big deal. And you're going to get serotonin for pain relief, and some other very important things such as brain-derived neurotrophic factor, which really helps the cells to survive. There's also antioxidant and anti-inflammatory effects. I want to show a movie now. It's about 5 seconds. And what you can see here on the left is a fibroblast cell. It's from a mouse. This is from a physicist from Northwestern Medical School in Chicago. And you're going to see this fibroblast cell swim around the obstacle, like a piece of sand or something, under this microscope, and swim right to the light. There's a laser light that's going to be blinking over here. So let's see if we can make this load. Yep. So as soon as we turned on the blinking laser light, the fibroblast cell started heading for the light. The cells are just drawn to certain wavelengths. And I think that's why we also get good success with healing. Now, this is another short movie. This is a fibroblast cell, again, from a mouse. And the nucleus of the cell has been removed. There's no nucleus in there, but it's full of mitochondria. And as soon as we turn on the blinking light source, you will see it's like a reflex of the cell swimming to the light. It's really not hard to treat cells with lasers and LEDs. They like it. So the cell it seems like it's almost a reflex. And it's really helpful for us as we want to try to help these cells. So very quickly, going through part 2, quick review of treating traumatic brain injury, concussion, that sort of thing. The first report was only in 2011. We did that with Anita Saltmarsh and other people from the Boston VA, Mike Hamlin, et cetera. And then the second report was in 2014. We had 11 cases. This study was done at Harvard Medical School, Spaulding Rehabilitation Hospital with Ross Savant. And we had 11 chronic mild TBI cases, and they had persistent cognitive dysfunction problems for greater than 6 months. 6 out of the 11 were more than 2 years post-traumatic brain injury, and they were just going nowhere fast. It was just awful. They were really in bad shape. Okay, so we treated them with red and near-infrared LED diodes. They were held in place with a stocking cap. So there were 633 diodes here in the middle, and then the near-infrared 870 was around on the outside, held in place with the stocking cap, as I said, painless, non-invasive. So very quickly, the results, we had 11 cases, as I said. Let me see here. And most were car accidents, motor vehicle accidents, sports injuries, falling, skiing, skateboarding, that kind of thing, not football. Okay, so this is just showing you results for one of the tests, and we're going to talk about this often because it's an executive function. It's called the Stroop test, color word interference. The subject looks at a word and say it's R-E-D. The letters are R-E-D, but they're printed in green ink. So sometimes they're supposed to read the word, like says red, or sometimes they have to name the color of the ink. And that's called inhibition and switching, because you change the rules in the middle. It's hard, difficult test, and it's test for executive function, you know, how well are the frontal lobes working. So we have these 11 cases. Now, 0 score here is really in the 50th percentile. So that would be average score in this test. But we got 11 cases with traumatic brain injury, and pre-treatment, they're a full standard deviation below average. Now, these parallel lines are saying, okay, we're going to treat Monday, Wednesday, Friday, 3 times a week for 6 weeks. Then we stop treatment, we're going to test. So a week later, oh, look, as a group, they're almost up to the 50th percentile, which would be normal. We're still not treating, but we're going to test again 1 month after those 18 treatments, still improving. We're going to test again, and 2 months later, they're still improving. So once you gave those cells enough photons over this 6-week period, they started working and probably making their own ATP, et cetera. And they just continue to improve. Now, when we get to the football players, you're not going to see that. They're going to improve and then go down. So they'll come up and then go down because they have a progressive neurodegenerative disease. Now, meanwhile, back to these TBI cases at Spalding Rehab in Boston. 4 of them of the 11 had PTSD, post-traumatic stress disorder, hypervigilance, and a lot of fear. They easily agitated is really something. So all 4 improved. So this is the raw score. For civilians, anything 37 and above on the scale is considered PTSD. Military grade PTSD is a higher threshold. It's about 57. So one of them way up here, he came in at 77. There's really a lot of PTSD behavior. But we treat 1 week later, they start to come down. And then 1 month later, coming down, and 2 months later, still good. So that gave us a lot of hope that we could also help those with PTSD. Now, there are just some short anecdotal stories I wanted to show you here. One patient said, now I can write checks and pay bills and even read essays. He was a vice president, a big financial firm here in downtown Boston, but he was in a car accident way out here on Route 128. So for 5 years, he couldn't do anything, but now he could write checks, pay bills. And then down here, one of the cases had his PTSD, his TBI occurred on the job. He was working and he was sucked into a blast furnace. Oh dear. And he had recurring nightmares of that every night for almost 2 years before he came into the study, and treat him with the LEDs, deliver the red and near infrared photons, and his nightmares stopped after only 3 weeks of treatment. So there's a lot you can do to help these people because they can be suffering for months and years. We also studied their sleep, and you can see here that this was a 23-year-old man who worked at the VA hospital. It was in a bicycle accident with a car. And after the 1 week after the 18th treatment, he improved his average sleep time over a 1 week period at almost an hour, and then an hour and a half 2 months later. But he's not getting any more treatments in here. His brain got enough photons to basically heal itself. And this is a female veteran, 53 years old. She had been in Iraq and had suffered 30 to 50 improvised explosive device blast injuries, and she had a lot of problems, cognitive and PTSD. But you see, a week after the 18th treatment, her sleep improved by almost an hour. I think that she needed more home treatments because we get good results when they can do that. So also now here we have another story for traumatic brain injury, and they used lasers. And there were 10 cases, and they had significant improvement in cognition. And in 2019, there's another study. This is from Colorado. They had 12 cases, and they were all veterans. And they improved in cognition as well. And you can see in the brain here, you're looking at the right side of the brain, right frontal, right temporal, right parietal, and cerebellum down here. And this is the cerebral blood flow in the brain before any treatments, and blue means it's pretty low. That's not good. But then after the LED treatments, they use pulsed light-emitting diodes. You see there's much less of the low blood flow because we know that the photons, the red and near infrared, will promote vasodilation of the blood vessels. So you're going to get better circulation. So part 3, very quickly here, we're going to talk about football. So we ended up working with 4 ex-football players who met all the NIH criteria for, quote, possible CTE. So I want to begin by telling you what is CTE, chronic traumatic encephalopathy. You hear a lot about it on the television, etc. It is a progressive neurodegenerative disease, and it's associated with repetitive head impacts, particularly with athletes, and the football players, of course, seem to be getting the most coverage. But it occurs in women basketball players, and it occurs in soccer players, men and women. So it's a question of how many times can you hit the head before you really do have, eventually, maybe 20 or 30 years later, chronic traumatic encephalopathy syndrome. And that comes along with its own neuropathology, and there's abnormal protein deposits that here on the right, you can see this is a slice through the brain. The cortex is out here on the surface, the white matter's deeper. And you see these little brown spots, and that's a tau, T-A-U, tau deposit, hyperphosphorylated tau. And when you get more and more of them, as it goes on, stage 2 CTE, eventually you get them down here in the lower right-hand corner all over the brain. And it's a very, very terrible disease to get. They have behavioral disturbance, emotional outbursts, impulsivity that is very hard on the family. And they have depression. I mean, it's just amazing what's going on in this field of chronic traumatic encephalopathy. And everybody's trying to help them. So we had 4 cases. 4 ex-football players. They're playing American style. This is not soccer. 3 pro football, 1 in college, and they're all met the NIH criteria. They're aged 55 to 74. I mean, they were playing football 35 to 55 years ago, professional football. And they played for high school and college and on to NFL for 11 to 16 years. It's estimated that any given football player, by the time they're done with their career, they have sustained thousands of repetitive impacts to the head and the brain, thousands. But some people develop it, some do not. We're still working on it at the BU CTE Center. And there are criteria now for diagnosing CTE in the living as best they can. They use, they're supposedly only wait till there's postmortem and you see all these tau deposits in the cortex and eventually all over the brain. It's just terrible. But they can document worsening cognition and behavior, mood, PTSD, et cetera, over years, 5 years, 10 years, 15 years. It begins as kind of a slow downhill course, but then it can go very fast in the end. So we also did, there's no known, I should mention, there's no known cure, and there is no known cure. They think they might be able to figure out a way to pull the tau out of the brain, the abnormal protein deposit, but nobody's figured out how to do that. These are the 4 cases you can see here in this column on the right, what positions they played. 3 out of the 4 were offensive or defensive players, and they were especially the linemen. They've done studies over the BUCTE that the offensive or defensive, the linemen, they're kind of going like this all the time as soon as the ball is snapped. And so their heads are getting bashed in, and they're the most vulnerable to develop CTE. So we used near infrared wavelengths in the 800s, continuous wave, no pulsing, 26 joules per cm square. That's just the way we talk in terms of energy with photobiomodulation. And they all started out with in-office treatments to the whole head 3 times a week, 6 weeks. And then we did post-testing. Of course, we tested before, and then we tested 1 week, 1 month, and 2 months after the last treatment. And then we have documentation some of them started to get worse because it's a progressive disease after we stopped. But then they treated at home, and I'll talk about that in a minute. And they brought themselves back up. It's really interesting. So then we have MRI studies on them too. So this is what it looked like in the beginning stages. When they're in the office, and we're treating them just the whole head. And we could use Medex Health LED cluster heads, or later we were able to get a helmet, and it was red and near infrared. So this is our first football player. He came to us when he was 65 years old. He played football 14 years, middle linebacker position on defense. He held the record and still does for the greatest number of tackles for Brigham Young University football. That's a big football college, and he still holds that record. Anyway, when he came to us, it was very sad. He had PTSD, no question about it. He had rating like military grade. It was so disturbing. And he's scoring at 57. Okay, now we treat Monday, Wednesday, Friday, 6 weeks, and it goes way, way down. Everybody's happy. A month later, still no treatment now, a little worse. 2 months later, getting not good. So then he buys his own equipment and he's going to treat at home. And I'm going to tell you about what this equipment is, and it's the default mode network. That's a certain intrinsic network in the brain, and he's going to treat that at home. So the same thing happened for his depression. It started coming back, and he had to treat at home, and his pain questionnaire, and so that goes up and that goes back down. So he did very well with treating at home, including on the color word interference test on the Stroop. And by the time he finished treating at home, he was the highest scores of ever, and even higher than after when we treated the whole head. So these intrinsic certain networks in the brain are really important to study, and he had improvement in visual spatial. So we're going to spend just a little bit of time on this default mode network, this very special intrinsic network in the brain. So here's P1. At 2 months after last treatment series in office, he started home treatments. And he's going to use this device. It's a NeuroGamma, V-Light NeuroGamma, and it's going to treat basically the default mode network. You can see they're listed here on the left side. What are these places? Mesial prefrontal right here. This little clear marble here is right over the mesial prefrontal cortex. On the diagram, you can see how forward it is there. The forehead is out here in front, and this precuneus high parietal. Now, these two nodes, they're in the middle of the head, and when you're asleep, they are very active. And when you're daydreaming, they are very, very active, very active. However, the default mode network must down-regulate in order for executive function or language problem solving even to occur. So these two, for them to down-regulate together, they have to be in the same low frequency harmonic coherence, just moving along together and down-regulate. Well, if you've got thousands of subconcussive hits to your forehead, eventually these two are not communicating. Mesial prefrontal high at the forehead or precuneus, they are not communicating. So they can't downregulate. They're in the way all the time, and you can't have good executive function. There's a few other areas that are also part of it, the left and right angular gyrus. And now we have to talk about treating the hippocampus. Hopefully you've heard of that. It's a memory center, but very, very deep in the brain. You cannot get at it easily, but you from out here somewhere. You have to, it's behind the hard palate, the soft palate, and above. It's very, very deep in the center of the brain on each side. So we're going to get there by treating through the nose, and we're going to send near infrared, 8-10 nanometers, up here to just the base of the brain, and just behind the eyebrow, and that's where we're going to send these photons. And we're going to treat, Monday, Wednesday, Friday for 6 weeks. Now, this default mode network is vulnerable in all kinds of disorders: stroke, TBI, PTSD, depression, chronic pain, opioid addiction, and so on and so forth, and aging, and autism. This is so vulnerable. One of the really big name researchers, Rachel, said that this is the most demanding part of the brain for glucose and energy, and it is so vulnerable. That's why you really have to have respect for the default mode network and all those disorders. And this device is going to treat the default mode network, and it's going to be pulsed at 40 hertz because of a study with MIT with Alzheimer's disease mice. They found that they treated 1 hour a day in a dark room for 7 days, but through the eyes, and no lasers or LEDs or red or near infrared. It's just room light. But that activated something called the microglia, when you do it at 40 hertz. And these little red dots all around here are either amyloid beta or tau, abnormal protein deposits. But the microglia can now sort of encase these abnormal protein deposits and get rid of them through lymphatics and the blood vessel drainage. And they got rid of 60% of those, but only in the back of the brain, because the light was shown through the eyes. It wasn't the whole head, et cetera, et cetera. But they also got a reduction in tau, TAU. And that's what's built up in the football players with the CTE. There's more to this, but we got to move along. So,
excuse me,
yeah,
Dr.
what do you want to take a break?
Yeah, Dr. Naeser,
Okay.
we're going to have to we're going to have to go on to part B next week. So everybody who has enjoyed this, I think we're going to have to slide the rest, because I know you got so much here that
we
people
have more, but that's okay.
need to learn. So we'll do we're going to just do a quick commercial break, quick commercial break, and then answer a few questions. Okay, thank you. And just stay there, but we'll yep. Oh, you got to turn the share screen off.
Oh, okay. Stop share. Okay.
There we go. And okay. All right. So I'll do my quick commercial right now, and I'm asking everybody to send in their questions. We're obviously not going to be able to get to all the questions that come in, but we'll try and get to some. So very quick commercial break here. So we have the SunPowerLED devices. This device here is the professional, and then we have the ultimate. Both these devices have the 660 and 810 nanometer. What's different is the ultimate has 25% more power, which can help as far as penetration depth. And you can see the light going right through my hand. I've got a very bright light here, so yeah, that's how you can see it. Anyways, that's 660, and 810, if you could see it, is actually going much deeper and coming out the other side of my hand much more. So this is how we've been talking, Dr. Naeser has been talking about different helmets. This is our helmet that we designed, and it has the two wavelengths of the 660 and the 810 nanometer. You can see it in there, the little purplish dots. That just goes down on top of the head and gives the light, the energy into the brain. And the treatment can be, treatment range can be, well, we're looking at 1 minute of red and 3 minutes of the near infrared. So that has been able to help with strokes, has been able to help with concussions. Next week, we're going to have a video that'll show a dramatic change in one treatment for a young fellow that had a pretty severe concussion. Still, I guess it's still labeled as mild, but anyways, but just that he had memory loss. He had a lot of different things. He didn't have brain bleed, but the very next day, from day before, he couldn't read a sentence, to the next day after the treatment, he was able to read a whole book. So that's the type of improvement that he had. Now, I know kids are young, when they're young, they heal fast, but that's pretty major, and it's in the acute phase, which can also heal much faster. So it's not conclusive, but really good turnaround for this young boy. And I've seen this a few times now, extremely quickly. So even another kid with, in 1 week after falling off a fence 8 feet high, banged his head pretty good and was having double vision. And after the light treatment was, one treatment was 2 days later, was able to remove the patch and have a single vision, like proper vision. This happens to be our mini canopy, this device. And it has it's basically 15 times the area of the palm light, but the same type of intensity. So we have the 660, this is the 810 nanometer. You can barely see it there because the camera can't pick it up very well. And we have the 660 nanometer as well. So those are the different devices we have, please visit our website to be able to purchase under products. And okay, we're going to now shift over into, our time is very limited here. We're going to shift over to answering some of these questions. Are there any evidence that PBM can decrease cardiac inflammation? This is a very good, like this has to do as well with, I'll answer this one, with myocarditis, the possibility of us helping myocarditis. And I've got Dr. Praveen Irani and a few other researchers and Dr. Ryan Cole, all who believe that we could make a difference on reducing the inflammation on the heart. So if you'd like to send us an email, we'll try and follow through with that. We're hoping that we can get a study going somewhere to help the heart. Okay. Any studies completed on functional neurological dysfunction precipitated by TBI? Go ahead, Dr. Naeser.
I don't know exactly what you mean by functional neurological, because we do have MRI studies imaging before and after, and I was about to get into that my next slide, but I guess we have to wait.
But I killed it.
Well, you didn't get to see it, and it's really beautiful. Although we treat the default mode network, we get changes in something called the salience, SALIENCE, salience network, and I have this brain here, and we deliver the photons to the center front of the forehead, high up at the hairline, but that comes in deep enough to get to something called anterior cingulate, and that's part of salience network. And on the side, there's a flip of the brain here, and you flip that out, and there's another cortex in here called the insula, and those two are very important parts of the salience network for attention to what's in your environment or internal. And many people think there's a lot of psychiatric disorders associated with imbalance in the salience network. And I'm very optimistic about treating those, especially PTSD. Yeah.
Well, thank you for the answer for that. We got a question from Bren. Does the treatment unit device have to be directly on the skin, or would a panel unit at 6 to 12 inches distance be still effective? And I can tell you, with the energy that we have out of our panel here, this has the potential to be able to be like 6 inches away. But for most of I would suggest that if we're looking at trying to get the higher levels of energy, you're going to be about 1 inch away. Now, that differs a lot from a lot of the toys that are on Amazon. And part of the reason there is they've used focused LEDs. I can't get into all that, but we're going to create a special video just to explain the differences. What's the difference between having a high level of light over a large area compared to one little spot, a few spots of high energy light? It turns out that the high level of light over a large area can penetrate much deeper. Okay, another question here is cytochrome C oxidase really the only target? Seems unrealistic with thousands of proteins present in the cell. Is this well established, or is it still more of a hypothesis? Seems like it absorbs 600 nanometers. What about wavelengths like 1050? Go for it, Dr. Naeser.
Well, you have more experience with 1050 than I do. I do believe, according to Mike Hamlin, and he's the really virologist and cell biologist from Mass General Hospital, who talks about this. And the original studies were done for the red wavelength absorption of the mitochondria in the rat liver in Italy by Passarella, I think his name is, way back in the 1980s. And that's been repeated several times. As far as I know, it's well accepted that it's effect on the mitochondria. But yes, you're right, there's anti-inflammatory effects. There are many other effects. And they were all listed there: collagen, increased serotonin, very good studies on serotonin, measuring the increase in serotonin in the 5-hydroxy HTT in the urine of pain patients. And they start out, they don't have good serotonin levels in their body, but the more you treat them, the more level of the serotonin they have. And you can measure the 5-hydroxy acetic acid in the urine. So there's a lot of biomarkers or ways to measure the cellular effects. I'd love to know more myself.
Okay,
Oh, now.
let's go to the next question from Dr. Barbara Zedler. Hi, Barb.
Oh, hi.
What is the typical or average home long-term maintenance treatment regime as far as the duration of each exposure, our red light and near infrared frequency? And I'm not sure what the TID, QID is all
Yeah,
about.
3 times a day, 4 times a day.
Yeah,
Is
oh,
it
okay. Oh,
more than twice a day,
okay.
3 times a day? Yeah.
All right, yes.
Twice a day, etc.
And
Well,
go for it. Yeah,
I don't know. I don't have an answer for you. I think that's something we're still working on researching out. In the beginning, apparently everybody wanted to do every other day, Monday, Wednesday, Friday, and we still do that. But it was especially when they were using lasers, low-level lasers.
in the clinic, because
in
the
the
clinic, because you
Mhm.
couldn't have people treating 3 times a day in a clinic. It
No.
would be very awkward to have a person come in every day for a treatment. So I think those
Right.
were the limiting forces. But now when you can have home units, I've been able to see people with severe injuries of different kinds respond very, very quickly when they're treating multiple times during a day. Somebody
In the
that
acute phase, I'm sure. Yeah, in the acute phase, burns and things like that. I'm
yeah,
sure.
and I think it's kind of like I use this analogy. It's kind of like, I don't know why, but we get hungry 3 times a day. Why wouldn't the cell get hungry?
Hungry. Why not? Especially if it's hypoxic.
Yeah,
Doesn't
exactly.
have enough oxygen anyway. So
Yeah.
yeah, that
Wh-
could be, but it does depend. And is it, what kind of is the disorder? How severe is it? And being able to treat at home with LEDs is now much better. But the issue in the beginning with when we were using lasers was it took 48 hours for some of the downstream effects to take place. But apparently that's different with LEDs. Anne Liebert, PhD, Sydney, Australia, is the expert on that. And so my advice is, I guess you can treat 3 times a week, every 48 hours if you want. If you're doing it at home, maybe you could try it 5 days a week. I really don't know. We don't have an answer.
Right. We're going to have to see even more research on that. So
Yeah.
those out there that have all the funds in the world to help Dr. Naeser and myself conduct more research,
We need
please,
money. Take a lot of
please
money.
join us.
Yeah.
Another quick question, and I think I'm going to have to call this the last question, because even though I would love, there's 2. This is tough. So I'll answer, how is near infrared different from far infrared? So far infrared, it does not penetrate the skin. It's long wavelengths and just feels nice and warm on the skin. Can help with detox, as it happens with saunas, but generally it's not something. Far infrared will not penetrate, where near infrared up to 1300 nanometer will. Okay, so here's one more question, and then I'm going to have to call it quits here because of a special event that we've got next again, right after this one. So can the Super Palm be used for different purposes, benefit the brain, such as general brain health and mental acuity, Alzheimer's, PTSD, strokes? Where would you place the device, and how long for there you go. So basically it depends on what you're trying to treat, and that's a very detailed answer. We'd have to go into this.
We're going to get into that next week, because I'm going to talk about stroke. If you got the stroke on the left side of your brain, only treat the left side of your brain. If you treat the right side or both sides, you're going to screw everything up. We'll get into that next week. It is not a simple answer. One protocol does not fix everything. Okay?
Yeah, exactly.
Really
So I
depends.
want to, and it is the Super Palm that's possible. I'll just mention one thing. We had a fellow with the seizures, and he knew where the problem was. They had done the scans and everything, and grand mal seizures, and he's treated with light, and he was much better. Than 2 years later, he ended up having the seizures again without any PBM treatments in between. And then he started using my palm light on the top of his head, exactly where the placement was that they figured was the trigger for the seizures. And now it's 2.5 years, he's free of seizures. So yes, the Super Palm Light and even the Palm Professional or Ultimate can reach into the brain. So I want
Especially
to
if you
thank,
put it where there's damage. I mean, you really want to know what you're working with. And I want to answer the next one quickly. We do not put it over a cancerous tumor in the brain. We never talk about putting LEDs, at least now, over a glioblastoma. So
yeah.
that would be useful.
Okay. I want to thank you, Dr. Naeser, for coming on tonight. And we want to invite everybody. We'll copy all these questions, and we'll try and take more time. Maybe we'll have more time next week to answer some of those questions. So thank you, Dr. Naeser, for coming on. Thank you, everyone, for joining us tonight. Tell everybody about this, because the number of people that have brain injuries out there that PBM can help is phenomenal, and we just need this thing to take off. So tell everybody about this. Thank you again, Dr. Naeser, for your wonderful knowledge and time that you took with us tonight.
It's great. Thank you. We'll look forward to next week.
Okay. All right. Bye for now.
Bye.